Dear ladies and gentlemen, dear Chairman, thank you very much for the invitation to this Congress and the opportunity to give the presentation about perioperative concepts in pancreatic surgery. I would like to talk about novel aspects in perioperative therapies in pancreatic cancer and the decision when and which patient to operate or not to operate. To start with how to operate, there has been nothing really new within the last years. Considering the type of resection, whether we do a pylorus preserving PD or a classical couch-Whipple resection, we know that the oncological long-term survival is similar between these two types of resection. We believe that the quality of life is a bit better after pylorus preserving PD. However, in the long-term follow-up, the differences are rather small. I think there's no doubt today about the extent of the lymph node dissection. The standard D2 lymphadenectomy should be the standard. We know that the extended lymph node dissection increases the operative morbidity without giving any oncological benefit in the long-term survival for those patients. Portal vein resection should be performed whenever it is necessary, and we know that it can be performed without increased morbidity in experienced centers. The main aspect is to achieve an R0 resection and should be therefore considered as standard therapy. The decision for or against a multivisceral resection should be chosen very carefully and based on individual decisions, and is not generally recommended in pancreatic surgery. For pancreatic cancer of the body and the tail, the distal pancreatectomy in combination with a splenectomy is standard of care. This can be extended to a subtotal distal pancreatectomy in combination with the radical lymph node dissection and splenectomy. There is some progress in technical aspects in pancreatic cancer surgery. The German national guidelines and also the NCCN guidelines today recommend a minimal invasive approach in distal pancreatectomy whenever it is feasible due to anatomical and tumor reasons. Minimal invasive approaches in pancreatic head resections are still based on individual decisions and should be performed within clinical trials because the evidence is far too low to give general recommendations. I will not talk about the aspects of extended surgery like arterial resections, surgery of local recurrent liver metastasis, and so on. We hear and talk later on about the concept of oligometastasis in pancreatic cancer, and I will not go into detail on this aspect. Here's a meta-analysis, what we have of evidence about laparoscopic against open surgery in pancreatic head resections. There are 3 larger trials with about 150 patients in total. What you can see here is, well, within these studies, no difference in patient characteristics, operative characteristics like the type of resection and histological findings. You have to keep in mind the tumors were smaller without any kind of vascular involvement. I think this is not feasible for minimal invasive surgery today. Well, I've chosen just one parameter here, the R0 resection rate, that is pretty similar between open surgery and laparoscopic surgery without any large difference. So laparoscopic approaches are feasible either by laparoscopic or robotic surgery. You have to keep in mind that the evidence that is originated within those studies are from very high volume centers with surgeons that had a very, very high experience in pancreatic surgery and minimal invasive surgery. And I think you cannot easily transfer those results into the wide field of pancreatic. So to go on with when and who to operate. You know these three types of patients with pancreatic cancer. The clear resectable tumor, the locally advanced tumor with a arterial involvement here, and the largest group of patients with distant metastasis at the time of diagnosis. I would like to talk about the first group here. What you all know as pancreatic surgeons is there is still some kind of a black box to see whether a patient is really resectable or not until you have the tumor in your own hand, and to see if you have a resection plane between the large vessels here, the SMV or the superior mesenteric artery. So the current therapy algorithm is that a patient that is potentially resectable in the preoperative CT scan should undergo direct surgery. And after the adjuvant therapy data from Conroy, adding modified FOLFIRINOX in the adjuvant setting, we know that survival rates of about 5 years is achievable in the resectable stage. However, we have a high frequency of local recurrence after tumor resections, and the idea behind this is, can neoadjuvant therapy improve the outcome in those patients? Well, the idea behind neoadjuvant therapy in pancreatic cancer is not new. We know that neoadjuvant therapy is standard in breast cancer, esophageal and rectal cancer. And the idea behind this is at first a tumor downstaging to achieve a higher frequency of R0 resections. We know that there is a high amount of patients that does not receive the full protocol of adjuvant therapy after pancreatic surgery. This is especially true for older patients that suffer perioperative complications, and those patients are not fit enough to receive an sufficient adjuvant therapy. And at last, a point, we can select patients by their tumor biology with the neoadjuvant therapy. We all know those cases after a tumor resection with a very early recurrence weeks after the surgery due to a highly aggressive tumor. Those patients will get a tumor progress under neoadjuvant therapy, and we know that those patients are not feasible for an operation. So what data do we have? Here's a large retrospective analysis from the US analyzing about 15,000 patients. What you can see here, that the patients that received any kind of neoadjuvant therapy, either chemo or chemoradiation therapy, performed better with a median overall survival of 26 months compared to 21 months in the control group with upfront surgery. This is reflected in smaller tumor stages, less lymph node involvement, less positive resection margin, and remarkable, the overall complications rate are comparable between the two groups. However, these are retrospective data. Prospective data from clinical controlled trials is rarely present. There are only 3 randomized controlled trials with less than 100 patients in total included. The applied neoadjuvant regimes were different between chemotherapy and chemoradiation therapy. However, in this meta-analysis, the overall survival was better in the neoadjuvant group in this series, 19 months compared to 15 months in the upfront surgery group. But what is really remarkable is the high rate of R0 resections of about 90% in the neoadjuvant group. Why this is important, you can see it here. First described by Caroline Verbeke from Leeds in 2008, the true R0 resection is one of the main drivers for oncological long-term survival. You know, when you have tumor cells within 1 millimeter to the resection margin, the R0 resection should be considered more or less than R1, and the patients have a similar poor outcome than a true R1 resection. Well, there is an interesting study from Japan, from the Japan Pancreatic Cancer Group. They combined gemcitabine and S1 in the preoperative setting compared to upfront surgery. What you can see here, the overall survival is really remarkable, with 37 months in the neoadjuvant group compared to 26 months in the upfront surgery group. Those results are not really transferable to Europe because S1 is not effective in European humans, but I think this study gives an impression where further results can lead to. We have a study from the Dutch group from the Netherlands, published last year, the Perioperative trial. The results are really more or less disappointing. We have again an increased R0 resection rate in the preoperative chemoradiation group, but the overall survival in this study was pretty bad, with a median overall survival at 15 months in both groups. This is by far worse than it is described in the adjuvant study from Conroy with the modified FOLFIRINOX. Today we do not know exactly what happened in this trial, why the overall survival rate is so bad. I think we have to wait for further follow-up, details, and especially the data for adjuvant therapy after surgery. So today, two multi-center prospective trials are ongoing. The first from Norway, the NORPACT-1 trial, comparing modified FOLFIRINOX in the neoadjuvant therapy setting compared to upfront surgery. The second is a German trial, the Neoadjuvant trial, that completed the patient enrollment a few months ago, and we're still waiting for the first results. 166 patients were randomized 1-to-1, and the chemotherapy arm received combination therapy of gemcitabine and nab-paclitaxel preoperatively compared to the group of upfront surgery. Today I cannot show you the results because I don't know them. Our center also included patients here, and we are full of expectation what the results will bring. So let me summarize what is new in the perioperative setting. Today, the surgery first is the recommended algorithm pathway for patients with a local resectable tumor. The resection status and the lymph node involvement are still important pathological prognostic markers. I think by far the prognosis determining factor is the lymph node involvement. In my personal view, I think neoadjuvant therapy will become standard of care within the next years because the data we have are promising. But today the evidence level is by far too low to give a general recommendation. Especially, we do not know which kind of therapy should be applied. Either FOLFIRINOX, gemcitabine, chemoradiation, S1, immune checkpoint inhibition, and so on. We do not know, and I think within the next years we will have some answers for those questions. Thank you very much for your attention, and hopefully see you soon in Cologne. Thank you. Goodbye.